All right. What questions can I answer for you before I get started? I was almost late. Traffic was terrible, but I said, made the executive decision. I gotta get coffee at least first, otherwise it's just not gonna go well. So I still made it in time though. Anyway, it's always my goal is to be responsible with your time. Any questions from? I grade all the prescription assignments. Wellbutrin, I think, is a tricky drug that a lot of people misprescribe. So I'm glad you made the mistakes now that you did. If you did make mistakes, or if you didn't make mistakes, you easily could have, and I'd like to explain that real quick. So Wellbutrin's a tricky one because I see that error happen all the time where the nurse will do the medication reconciliation for patients. They come to the ER, going to get admitted, and say, hey, what do you take? And they say, well, I take Wellbutrin. How much do you take? 150 milligrams, and that's all they write down on the chart. And then you as a provider, if you're admitting the patient, you have to hit reorder, and then they come through and you don't know any more information. That is it once a day? Is it twice a day? All of that makes a really big difference because it comes in two big formulations you're going to find. There's the SR formulation and the XL formulation. Which one's every 12 hours? SR. Which one's the Q24 hour? Does that seem logical based off the name? One's sustained release, one's extended release, right? Doesn't it sound like the exact same thing, right? But that's why it's so common as a medication error. Is I will have people who were actually on the SR formulation get ordered at only one time a day, which means they could have some errors with that, right? Because now they're getting the wrong dose, or either getting an underdose or overdose, depending on the case, or the vice versa could happen, right? So you can have the XL formulation being ordered twice daily, potentially. That's why it's so important to make sure you get a good, accurate history on what they were actually receiving there. Okay, so that was a big thing I just wanted to know, is be very explicit on your prescription when you're writing that, which one you actually want. Now, from context clues, me as a pharmacist, I can probably figure out you wrote every 12 hours, or to bump them up eventually to Q12 hours, that's probably what you wanted, but again, I don't want to have to make any guessing on my part, because if I have to start making assumptions, what happens? Assumptions could be incorrect, right? Exactly. So then that will have to prevent some phone calls to you from the pharmacy if you're very explicit on all that stuff. Okay. Anyway, any other questions on any of those prescriptions? They're pretty straightforward other than that for the most part. Yeah, for the controlled substances, really make sure you're spelling out, and I didn't count anyone off on this, but I forgot to make that very clear, is you want to write out in actual text the amount to dispense. Because again, if I write down 10 mLs, someone can add on an extra 0 on the end of there, and then that changes the prescription pretty greatly. Do you have a question? Yeah, as long as you're within 10%, generally you're going to be pretty good for the most part. So again, for the mercaptopurine, I think it was like 0.96 is what you end up calculating. If you round it up to 1, I'm not going to really fault that too much. You're right, because it is a cancer drug that you're like, I want to be a little bit more exact, and that's absolutely true, right? That's totally fine. 0.96 is really hard to draw up on a oral syringe, so it's one of those things where if you round it to 1, I'm not gonna fight you on that one, right? If it's an IV medication, especially for like a NICU baby or something, that way, in that situation, we'd want to be a little bit more exact with our rounding and be much more careful with those patients, because again, when you're dealing with a kid who may be less than a kilo, like it's a very small amounts, small changes in the drug dosing can make a big difference for that child, right? Any other questions? Pretty straightforward. All right, fantastic. And your second assignment is up as well. That's going to be one of those inpatient order sets, right? So you're actually going to write down a few different medications for a patient who's post-appendectomy, I believe. So again, and I see PAs writing those orders all day, every day. From my standpoint, when I'm working at Nemours, all these kids are coming out of surgery, PAs are writing all the admin orders, and so you guys need to be well versed in that, right? So this is a good place to make mistakes. I know you guys don't want to get points counted off on your grade, but this is a good opportunity to make mistakes, because again, there's low probability of you hurting anyone on a prescription assignment right here, versus when you're actually out there on rotations or actually as a practicing provider. And also, I will be at FAPA on Sunday morning if you guys happen to be there, the coveted Sunday 8 o'clock slot.
You're not going to Rainbow?
Huh?
Rainbow?
I'm going to try to. I'm going to see. I will root for all of my students. It's like just like I have no favorite children. I always tell my children, I said, you're my favorite first child, and you're my favorite second child. Just like I tell my wife, you're my favorite first and hopefully last wife. So it's all important about how you say things. Well, I got to see if I can even make it there, because I might have my other two children, my actual children, that I have to worry about. 7 o'clock is the witching hour. Yeah, it's really tough. Yes, ma'am.
I just wanted to let you know, it says that the assignment 2 is not published yet.
It's not published yet. Okay, I'll fix that. It's probably a button I need to click. So, okay, I'll fix that on the break. Anyway, so let's get back into our behavioral meds. I need to finish this up quick so we can get into the neurology stuff, right? So we were talking about antipsychotics, our first generations. What's the main mechanism of action for our first generation antipsychotics? Dopamine receptor blockade, D2 receptor blockade. That leads us to our extrapyramidal side effects. That's why we get things like the tremor. That's why we get the things like the extrapyramidal side effects, the hyperprolactinemia. All those things come about from dopamine receptor blockade. The second generation agents, the atypicals now, these are the newer ones that we're using a little bit more frequently, are going to be separating themselves a little bit because they have a little bit of dopamine receptor blockade, but they also separate themselves because they block the 5-HT receptors in the frontal cortex. That's one of the big things they're going to be doing here, right? So 5-HT2 receptors primarily. And so we're going to find that these are much better for the negative and the cognitive symptoms of schizophrenia. There's some pretty good for the positive symptoms as well. Maybe not as great as something like Haldol if you had a patient who's like actively hallucinating and is agitated and is a danger to someone. But typically these are starting to be first-line agents because they don't block the dopamine 2 receptors as strongly. They also don't cause that tardive dyskinesia, right? Remember that was that dopamine receptor hypersensitivity that occurs over time that's oftentimes irreversible. So that's one of the big differences here why most people are going to be on a second generation agent. As I mentioned, they have less affinity for D2 receptors, but that 5-HT2 antagonism is going to be the best thing about these, and they're going to be doing that in the frontal cortex, and that helps to re-regulate that dopamine receptor activity. We'll see that. I'll show you that in just a minute. So again, if you're looking at this, looking at the nucleus accumbens versus the frontal cortex here, by having too much dopamine activity here, this is where we saw a lot of those positive symptoms, right? The hallucinations and things like that. Using our first generation agents, they were able to block this activity pretty well, but that led to a lot of worsening of the cognitive and the negative symptoms as well, because when you're blocking dopamine, you can't just pick what part of the brain you're doing it in, you have to do it everywhere, right? So by blocking dopamine here as well, you actually ended up causing worsened cognitive and negative symptoms, okay? By blocking serotonin, you're actually helping to re-regulate the dopamine activity here because this is normally inhibitory. So by taking this off, you're actually having more dopamine activity in the frontal cortex, and that then will cause this inhibitory neuron to fire more, which will inhibit dopamine activity here in the nucleus accumbens, right? Because we said for the positive symptoms, you have too much dopamine activity here in the nucleus accumbens, you have too little dopamine in the frontal cortex, and by using these atypical agents, you're going to re-regulate that. Okay, so what do you need to know at the minimum for testing purposes? No, it's a 5-HT2 antagonist, and that helps a lot with the negative and cognitive symptoms, much more so than the typical agents. Okay, you want to get much more down the rabbit hole on that? We can definitely have that conversation, but I don't want to overwhelm you at this point, right? I think I got too much to cover. But adverse effects are very notable with this one. There's a lot of metabolic side effects associated with these, namely weight gain's huge with these. Okay, huge. That's no pun intended. But you're going to see a lot of weight gain. Some people will put on 20, 30 pounds of these agents, right? So it helps a lot with their symptoms, but they feel terrible because they're getting all this weight. It's worse with clozapine and olanzapine. Those are two of the big ones that are going to cause that. And typically the lowest was something like ziprasidone or aripiprazole. I'll show you the full list of drugs in a few minutes here. And actually, if they see more than a 5% weight gain, that is recommended to switch them over to a different agent. Right. Most people probably start off with something like aripiprazole, but for more difficult to treat symptoms, something like olanzapine may be necessary, and they're just going to have to deal with the weight gain in some cases, right? So I have to work on it from a non-pharmacologic standpoint as well, but that's just a known side effect. Other things, glucose intolerance, right? So you can see new onset diabetes because of this. It's kind of worse with clozapine, which again we saw is worse with weight gain as well. So those kind of go hand in hand, and hyperlipidemia. Okay. So again, especially these older patients may be dealing with these anyway. So this is just going to compound that, right? Clozapine is a drug you really never want to use unless you have really failed all other therapies, mainly because they have this REMS program for it because it causes agranulocytosis. What could happen if you have agranulocytosis? Yeah, fatal infections basically. They can't fight off an infection. They get fungal, viral, bacterial, whatever. They can die from that, right? So it's a 1% incidence, which means every 100 patients you treat, one person could develop that, right? So it's very, it's definitely not a risk you want to take for most patients. You have to do constant monitoring of their CBCs, etc. So you do not want to use this unless absolutely necessary. It's clozapine or Clozaril is the brand name for that. Most of them are going to cause QT prolongation. So if you imagine if I had a patient who had really difficult to treat depression, and I had them on, say, something like escitalopram, and then I have them on, something like aripiprazole on top of that, and then they decide they want to harm themselves, and they take all their medications. This is where you start to see a lot of QT prolongation starting to occur. That's your QT gets up to like 600, and you can start to see things like torsades develop, right? So those are things you want to think about in the case of things like overdose. And then the other big ones are going to be a lot of orthostatic hypotension associated with these. Orthostatic hypotension can lead to what? Falls, right? So dizziness, falls, right? So those are things you want to consider. More so, you're going to see this with the elderly patients, right? Because they're not going to have that same hemodynamic sort of stability as younger patients would, and usually will develop tolerance over a couple of months or so. When do you think would be the best time to administer these if you're worried about that? Probably nighttime, right? So that way they're going to be asleep anyway, laying down. Hopefully they don't have like a bunch of diuretics on board, or they have to get up and go, urinate in the middle of the night, because that could lead to falls, potentially. But that is something you want to warn about. Okay. These do have a black box warning. So one of the things you're going to find with elderly patients is that, especially when they're like in the hospital setting, or if they're taken out of their normal home environment, they get a little loopy in the evening times, right? So what do they call that? Sundowning, right? And it can be very kind of problematic for them. They can get very agitated. It's a problem for the family if they're seeing their loved ones starting to act like that, and it can be kind of difficult to manage. And so you can see that sometimes you just have worsening dementia occurring with these patients. And so some people feel like, okay, well, this looks like they're getting psychotic or something. Let's treat that with an antipsychotic. It's good for sedating them and chilling them out, but they actually find there's an increased risk for death associated with this. So again, when you have these patients who are getting, elderly patients, or their dementia is getting worse, this dementia-related psychosis, something like a antipsychotic is not going to be good for them. Something like a benzo might be a better option potentially, right? So like a lorazepam or something like that. We'll talk about the benzos later. Are good to help kind of chill them out a little bit, and overall they're not associated with that same risk of death. So that's a black box warning to note about those. Sedation is a huge one with this. This whole class here, so it has a lot of sedation. Clozapine, olanzapine, quetiapine are known for this as well. That's why we like to give it usually at nighttime. So that way it helps with sleep. And again, schizophrenic patients may have issues with sleep anyway, so this can kind of help with that as well. Okay, and a lot of them are going to have some anticholinergic effects. Anticholinergic effects we know by what mnemonic? Dries the bone, has that right. And again, why do I keep repeating these things all the time? To make sure you know it, right? Because again, repetition is the key to adult learning, right? Repetition is the key to adult learning, right? Repetition. Okay, anyway, you get the point. So be aware of those things, right? And then also, these drugs have a tendency to lower the seizure threshold, which makes it more likely for someone to have a seizure, especially an overdose. That's something we want to be concerned about as well. Okay. Again, generally when you're combining these different medications together, sedation, or again, the pharmacodynamic effects are the big things you want to worry about. So if I had someone who's on a benzodiazepine plus one of these atypical drugs, you're going to see increased sedation, right? If I had them on a TCA plus one of these atypicals, you're going to see increased sedation, right? Again, all that has to do with these drugs working synergistically together. If I have them on a TCA, we know that has alpha blocking effects that can cause orthostatic hypotension. This is going to worsen that, right? So again, think about the drugs you're mixing together and what kind of effects they can kind of add on to one another. Okay. Just know if you were to combine any other dopamine blocking drugs, this is also going to increase your risk for EPS. So if I had something like metoclopramide or Reglan, remember we talked about that for being an antiemetic, as dopamine blockade. Phenergan or promethazine has a dopamine blockade. So be careful mixing these together. So this is the list of the atypical antipsychotics. You can see some of the more common ones include things like Abilify. We have things like Geodon. You have things like Zyprexa, Seroquel. Again, don't memorize how many stars are in each of these boxes here, but I want you to get a general feel for what kind of side effects you're going to expect to see with these. So like I mentioned with clozapine, a lot of side effects with this. And we mentioned that agranulocytosis. That's a unique thing with clozapine. That's why we don't use it very often unless they failed basically everything else, right? But looking at things like risperidone, a lot of side effects. Hyperprolactinemia, right? So we know this one probably has a little bit more of that D2 receptor blockade. You can see with that, right? However, something like Abilify, relatively low on a lot of these side effects here, maybe a good one to start out with for most patients, right? Because again, less weight gain associated with it, So you can just get a general feel for these different agents and be able to recognize them as an atypical antipsychotic, right? So again, the big things to know, at least for testing purposes, if I mention specifically something like olanzapine is really bad for weight gain, that's something I want you to know. If I mention agranulocytosis with clozapine, that's what I want you to know, right? And again, this chart can kind of be helpful in trying to get you to kind of recognizing some of those kind of big differentiators, okay? Anyway, this is another table kind of comparing your typical versus atypicals and kind of looking at those together to see how their side effect profiles change a little bit between the two. Okay. Again, you're going to find the atypicals probably act a little bit more like your lower potency dopamine blockers, like your chlorpromazine or something, versus something like a high potency D2 blocker like haloperidol, which are more likely to cause EPS, tardive dyskinesia, etc. Okay. So good chart just to kind of compare things together. So as far as monitoring goes, obviously you're monitoring a lot of the metabolic parameters like weight, looking at their fasting plasma glucose, their lipids, all of that good stuff. And again, just let them know, like, hey, these are side effects we're looking for. So if you notice anything like increased muscle tone, if you notice any kind of like tics or tremors or anything like that, those are things that you could see potentially, could be signs of that EPS, etc. Okay, the EPS is not completely not possible with atypicals, but it's just less likely, right? Okay, so for acute treatment for schizophrenia, typically you're trying to, if you have a patient who's having acute sort of positive symptoms, you want to deal with those first. That's mainly the big thing you're looking for. If you need to calm someone down, benzodiazepines can be very useful. We'll talk more about those in the anxiety section coming up. And basically we're going to be titrating our dose up to basically to where to see how the drugs are tolerated, to see how efficacious they're going to be there. And basically, if they're not responding within 3 to 4 weeks or so, we can try switching up different agents. Some patients may not respond well to quetiapine, Seroquel. They may respond better to something like Abilify, right? So again, you can switch within the class in order to find something that's going to work for your patient there. Most of the time, patients are not going to necessarily stop treatment based off of the efficacy of the drug, but more likely the side effects of it. So that could be one reason why you might want to switch within these agents here. And then for some patients, if you're worried about compliance issues, which we know is a big problem with these patients, because a lot of times they may not feel like they need treatment, you're going to find that you can use long-acting injectable forms. That way, they basically will anyone heard of like a depot effect? What does that mean? DEPOT, right? So when you think of like Home Depot, what is that? The big store just kind of full of stuff for the home, right? This is kind of what we're doing. This is a depot injection essentially. So if you ever hear like a depot shot for like birth control, that's what we're doing. Basically, it's an intramuscular injection where you're putting a lot of the drug in there. Usually it's an oil sort of base that doesn't dissolve very easily, and it slowly leaches out drug into the systemic circulation over time, usually over the course of several months. So if you ever heard of like a depot shot or a depot form of a drug, that's what we're talking about essentially, right? So it's a long-acting form, and again, once it's in the muscle, you can't really do anything with it, so that way your compliance is ensured, right? So if I had someone I was really worried about, taking their birth control, if I give them the depot shot, they're pretty well ensured to be compliant because I injected it into the muscle. I know it's there, right? So anyway, so that's something you can consider if you're really worried about that. Nowadays in the ER, we're kind of moving away from using more things like Haldol, and we're using more of the atypical antipsychotics nowadays. So something like Geodon or Zyprexa are getting used in the intramuscular route. And why do you think we need to use these agents as an intramuscular route for these acutely psychotic patients? They may not take any pills, right? Pills take time to work. What about an IV? They're either going to rip it out, or they're going to be fighting you, they're not going to hold still. So oftentimes you need intramuscular medications to chill them out enough to where you can actually get the IV started, get them in restraints if you need to. So that's why intramuscular medications can be very useful. We have like a little Haldol blow dart you can across the room, and so. But nowadays we use atypical ones, so now we get the Geodon darts. So. Anyway, if you need to discontinue therapy, usually you want to taper over the course of several weeks because you do worry about discontinuation syndrome, and they could have kind of rebound symptoms there. If it does start to occur, then you can kind of start them back at a little bit higher dose, whatever they tolerate, and then kind of titrate from there. And typically when you're switching agents, you don't want to have them go off cold turkey, so you want to kind of taper off of one as you're starting up the other one, so that way there's a little bit of cross coverage there, and that way they can hopefully not really have a whole lot of relapse of their symptoms. Okay, any questions on antipsychotics? Yes, sir. Yeah, so that's going to go with any of the atypical antipsychotics. They're really basically saying, I don't know the mechanism, right? So I don't know if they've really delineated why. They just see that elderly patients who are receiving that for dementia have a higher rate of dying than patients who did not. We don't know, right? Could be seizures, it could be, a host of number of things. I'm not really sure. So getting into anxiolytics, something you probably all need right before test day, right before my class starts. There's a lot of different anxiety disorders that are out there, right? And you're going to find the treatment is going to be generally the same for all of them as far as the medications we're going to use here. And a lot of the meds we've already talked about already, so it'll be just some review here. Some people say I have OCD so bad that I have CDO. Just a small joke. Anyway, you guys will all have PTSD after this class, so yeah, and I like that's good. Delayed reaction. Now, stress and anxiety, is that always a bad thing? No, stress can be a good thing. Anxiety can be a good thing. It can put you into a heightened state of awareness. You can respond to stressors a little bit better. However, if you're constantly in a state of anxiety, is that a good thing? No, you're stressing yourself out. You're going to have your glucocorticoids are going to be raging. You're going to have stress ulcers that can develop, all kinds of bad stuff, right? So we don't like that. But we think that the reasons why we are getting this maladaptive sort of stress disorder is mainly due to some dysregulation of things like norepinephrine, serotonin, and then GABA. What does GABA do in the brain? Inhibitor, it slows everything down essentially. So we're going to see that most of our drugs are going to be targeting one of these three neurotransmitters, okay? Because normally serotonin, norepinephrine, you think of that being inhibitory or stimulatory? Or usually stimulatory, right? So we're going to find some ways to try to regulate that can help us with these. Anyway, there's a lot of drugs that can cause anxiety, so like antipsychotics causing that akathisia. What is akathisia? That ants in your pants kind of feeling, right? So again, that's something that can be mistaken as anxiety. Digoxin toxicity, a lot of stimulants. So if you had someone who's on, say, phentermine for weight loss, if you had someone who was taking amphetamine, say for ADHD or something like that, all of that can lead to anxiety. And then you want to look at certain things like even withdrawal of drugs can actually lead to anxiety. So if you have someone who's on benzodiazepines or they're chronic drinkers and they're coming off of those medications, their basically brain's kind of set to really kind of high rates of activity, and you can even see seizures potentially. But before that, you can definitely have a lot of anxiety, right? So again, be careful of these chronic drinkers. If you see them like in the ER or something like that, they constantly live at a level of like 200. Once they start to withdraw, like you don't want them to be in your ER at that point, right? You want them to make sure that they are going to be gone by that point, right? Anyway.
Do you mean like alcohol? Because I thought it was a depressant.
Usually it's a depressant, but withdrawal from that depressant can be very problematic, right? You get the rebound effect. Because normally if you have something around all the time, so if, say you're a chronic drinker and you're drinking all the time and your level is constantly 200, like your brain gets used to having that effect around with that constant depressant effect. So when you remove that, your brain needs that around. You're physically dependent on that. All of a sudden your brain's going to be wired to go kind of in overdrive. And so that's why you can see rebound seizures that happen with withdrawal. We'll talk more about that in the benzo withdrawal in a little bit, because benzos and alcohol work very, very similar to one another, right? Yeah, absolutely. So, in fact, because you'll say, for instance, like you have a person who's a chronic drinker, you can get an alcohol level on them in the ER, and they could be 200 and have a conversation right now. Like I'm probably at like 300 or 400 right now, but we can be totally normal. But when you check that level and it looks like they're legally drunk, can you discharge them from your ER? You can't do it, right? You gotta wait for them to get sober, right? Get down below 80. Well, they might be start going into withdrawal at that point. They got to admit them for that. So oftentimes, I've seen a million ER residents, like for usually first or second years, they'll get an alcohol level on a patient that was like totally normal otherwise, and the attending is like, great, now we got to deal with this. Why the heck did you order that? Because it didn't change their management at all. But now they have to watch them until they actually get sober. But anyway, it's a little bit of an item. So our treatment, we're going to find supportive therapy, obviously going to be first line. So again, learning how to deal with stress, learning how to deal with things like test time anxiety and all of that to try to harness that anxiety to try to help you to be better on your exams, right? Or something like that can be very, very useful. But we're going to focus on the pharmacotherapy, obviously. For acute anxiety, we're going to find things like benzodiazepines are going to be our first line agents here, okay? And then from our chronic management, we're going to find antidepressants actually are going to be better for that, right? Because again, depression and anxiety oftentimes go hand in hand. Sometimes patients have a little bit more anxiety than depression, vice versa, but they both need to be treated for the most part in order to get good therapy there. And then we'll talk about a few alternative agents like Buspirone. We'll talk about some atypicals, antipsychotics, etc. So, and again, it's good to know how these different agents are going to be working for anxiety. So if I had a test question, I said someone is about to, have a panic attack and their, their heart rate's up, their blood pressure's up. What's the best agent to treat their anxiety right now? You need to know it's going to be working quickly. So that way, if I say I'm going to start them off on Paxil, 20 milligrams a day, it ain't going to work. It's going to take how long for it to kick in? 4 to 6 weeks, right, before it really kicks in. However, you could give them something in the meantime, something very fast acting to try to chill them out, and then you get them started in the SSRI. And so sometimes we'll do a little bit of what we call bridge therapy, right? Where you give them something fast acting to kind of get them to where the SSRIs are going to work, and then you can take them off that other med. Okay, so things to consider: how fast these are going to work. Just like we talked about with anaphylaxis, right? You can give them steroids when they have an actively anaphylaxing patient, but that's not going to save them right that moment. What's going to save them? The epi, right? So again, think about it in that kind of idea of like how fast these meds are going to kick in. Anyway, so antidepressants. And again, our standard go-to is going to be our SSRIs. Are going to be very effective for acute and long-term treatment of generalized anxiety disorder. And most other anxiety disorders typically are managed with SSRIs for the most part. You could also use some of your SNRIs as well. Some patients actually will get a little more anxious due to that norepinephrine effect, but that tends to go away with time. But things like venlafaxine, duloxetine, any of those are totally fine as well. Okay. Some patients may not respond well to that. They may need an atypical, a TCA. But again, try to go with the SSRI, SNRI first line if you can. Again, the full mechanism, we're not really sure. Maybe we're kind of helping to re-regulate some of those stress pathways, but we just know it tends to be effective. But it takes time. So again, several weeks, 4 to 6 weeks before you really start to see those full effects. And again, be aware of the side effects, right? Sexual dysfunction, weight gain potentially, QT prolongation with citalopram, those things like that. So again, review back on those slides and be aware of what the side effects are going to be for your antidepressants, okay? Now, our benzos, this is kind of a new class, and this is good we're talking about it here because we're going to move into neurology eventually. And basically, the mechanism that these are working on are going to be helping to enhance GABA's activity. Okay, they don't open up these GABA channels directly, but they help the GABA bind more easily to it, and they facilitate GABA binding more easily and helping to open that up. So you say, well, what the heck happens when you have a GABA channel being activated? What happens? Well, chloride's going to flow in. Chloride's going to flow along the concentration gradient, because what's a normal chloride in a patient? From the blood. Usually like the 1 teens or so, right? So again, we have a lot more chloride outside of the cells than we do on the inside of the cells, right? Again, go and do back to your BMP. A lot of this stuff makes sense. Like, why does sodium flow into the cell and the sodium channel's open? Well, because your sodium's like 135, right? Why does potassium flow out of the cell? Because your potassium's like 4, right, in the blood. So again, these things make sense when you think about the electrochemical gradient here. Anyway, so when you have these GABA channels, when you have benzodiazepines bind to those GABA channels, they're going to help to kind of change your conformation a little bit to allow GABA to bind more easily. GABA binds there, it's going to allow that channel to open up, and that's going to allow chloride to flow in. So what happens when chloride flows in? Makes it more negative, which makes it hyperpolarized, which means action potentials are less likely to occur, right? They're inhibited, okay? So this slows everything down, right? So again, this is how we treat seizures. This is how we treat acute anxiety, okay? By slowing everything down to try and inhibit this overactivity of these neurons, okay? What do you think needs higher doses to treat, a seizure or anxiety? Seizures. Probably seizures, right, if you think about it. But oftentimes you'll find the dosing is pretty similar between the two, depending on the case here. There's 2 main GABA channels we're going to talk about, GABA A and GABA B. I believe we probably talked about GABA B already a little bit with the muscle relaxants, skeletal muscle relaxants like baclofen and cyclobenzaprine. These are GABA A channels we're mainly focusing on now. The benzodiazepines work for GABA A channels. So what kind of side effects would you expect to see from the benzos? A lot of sedation, right? What else could we use these for? Insomnia, yeah, we can use them for sleep potentially, right? What else could you see as a side effect? What else could you see as a side effect? So that's interesting. So you say respiratory depression, which we definitely saw with the opioids. One of the things that was always told to me is that the only way you can die from a pure benzodiazepine overdose is if you get hit with the truck that's delivering them to you. Which I think illustrates a very good point that, in fact, these have a very good safety profile for the most part. And again, that's only with oral dosing, right? So what's nice is you can get very, very CNS depressed from this. You can be basically comatose. However, you will still retain that respiratory drive, which is great, right? Because again, you have patients who may take too much of this and become a problem. The issue is, are patients only taking benzodiazepines? No, oftentimes they're taking opioids on top of it. If they're taking skeletal muscle relaxants on top of that, that's where they get into trouble. And the synergy happens there, and then they absolutely can lose that respiratory drive, right? I always talked about patients coming in on oxysomanex, have oxycodone, Xanax, and Soma, and they take all those 3 together, and they would be very respiratory depressed and have to be intubated most of the time. So just know that. Oh yes, ma'am.
What about we used to use a lot of midazolam for sedation.
Yep.
And they like to use it just because a lot of patients actually remember.
Yes.
Some of it helps them not remember what it's.
Good. What do you call that? Amnesia. What kind of amnesia is it? So we talk about anterograde and retrograde amnesia, right? So anterograde means from the time they get the drug forward, they don't remember anything, versus retrograde, which means they don't remember anything that happened beforehand. So oftentimes we'll use that if patients coming in for procedural sedation, say they broke a bone or something. They'll remember breaking their bone, they'll remember falling off their bike or getting hit or whatever the case may be. But then once they get to the ER, everything gets a little foggy because that's when they got the drugs and they kind of don't remember having their, fracture being reduced, or whatever the case may be. And so, yeah, we like that amnestic quality of it. It's very good. And we'll oftentimes give it for, pre-surgical anxiety. We'll give it to these patients to try to calm down, and that starts like kind of the amnestic properties beforehand. So, yeah, a lot of good cases for why we use this. But also, that's why you have, what do you call it when you, like, say you're drinking too much and you don't remember what happened that night? Called blackouts. That's essentially what we're doing right here, right? We're causing a blackout for these patients. What happens if you only have kind of foggy memories of what happened?
Brownout.
Called a brownout, right? You have partial memories. I think I remember when we went to that place, that other bar, but, and again, I'm assuming none of you have ever experienced any of this, but your patients certainly will have. Okay, so it's good to know the difference between those two. Like, I kind of remember what happened. Oh, you had a brownout, right? I don't know that. Anywho, but yeah, that's directly related to hyperpolarizing all of these cells here and kind of inhibiting these action potentials. Okay. Other side effects, you can see ataxia, right? They're going to be more likely to fall. You're going to see things like mental slowing. They may have inhibited decreased inhibitions, right? So maybe more likely to do things they may not otherwise have done, right? Think about the social lubrication you see with alcohol, get a little extra gusto to maybe go talk to somebody you might not have talked to before, things like that. Same thing happens with the benzos. So you can kind of think about the same effects as alcohol, essentially. Now, we have a lot of different agents that are available here, so you should be able to recognize any of these as benzodiazepines, okay? So we have things like alprazolam or Xanax. We have things like clonazepam or Klonopin. A lot of these are good as oral agents. You may see patients on chronically, potentially. So you will find some patients are on like an as-needed sort of basis for these, where they'll just take it as needed for anxiety. Sometimes patients are going to be on this chronically, where they're saying taking Klonopin 3 times a day, every single day. That's a possibility, right? And then we have some good ones that are available parenterally, either IM, intranasal, or IV that we use in the hospital setting quite frequently, right? EMS or hospital setting. So things like diazepam is a good one. Things like midazolam, things like lorazepam. Those are very common ones we use IV or IM. Actually, we use a lot of intranasal Versed nowadays, midazolam, to help if the patient does not have an IV yet, right? So again, there's a lot of different options here. Now, you'll know I have 4 of these that are starred. These are what we call the LOT benzodiazepines, LOTT. Now, the things that will differentiate benzos from one another are oftentimes things like how water-soluble or fat-soluble they are, and they have things like active metabolites. When I say active metabolite, what does that mean? So they get broken down in the liver, and then some of those byproducts still have activity, right? They still can act like a benzo, essentially. And so when you're thinking about giving these things to older patients, what are some of those characteristics you think you'd want for all these older patients? It should break down easily. It should break down easily, and it should get out of the body easily, right? So if you have things like fat-soluble benzodiazepines, they're going to partition out to that tissue. They're going to stick around for a good long time, which means they're going to have increased duration of action. If they have active metabolites, that means they're going to have active drug around for longer. They're going to have longer duration of action, right? If you have poor liver function, maybe they're not going to be able to metabolize it as well, right? So this is why for older patients, we like to use water-soluble drugs that have no active metabolites from a benzodiazepine standpoint. And again, have you guys heard of the Beers list? I know I'm talking a lot about alcohol. This actually has nothing to do with alcohol, right? The Beers list is a list of drugs you do not want to give to elderly patients if possible, because they're more at risk for things like falls or mental clouding or worsened dementia or all of these different things. A lot of these benzos are actually on that Beers list. If you need to use one, though, it does occasionally occur, you want to use one of these LOT benzodiazepines. That's lorazepam, oxazepam, triazolam, and temazepam. These either are water-soluble, have no active metabolites, and have relatively short duration of action.
So, like, let's say, for instance, they're going to go on a 13-hour flight.
Mm-hmm.
You might want to give maybe like lorazepam so it can last longer?
Not necessarily. Lorazepam, so the ones that start are going to be the ones that are actually like a little bit shorter acting, if anything, because they get cleared a little bit easier.
I'm sorry, I thought that those were the fat ones.
No, so these are the ones you'd want to give to the elderly patients, right? So LOTT are the ones you'd want to use in elderly patients if you need to.
Okay. They used to give Halcyon around EO for sedation
Yep.
procedures,
Mm-hmm.
and then mostly were the elderly.
Yep.
And they would tell them just have it on empty stomach because it acts faster.
Yep. Yeah, and that one actually has a relatively short duration of action, which is why it's better for those elderly patients, right? So again, some of these things you might have seen in the past, you're like, oh, that's why they did that, right? Some of these are why we do the things we do, right? Some of it is related to the kinetics of the drugs themselves and why it might be better for one type of patient than another, right? Okay. So be able to see this. A lot of uses for these. You can use them for seizures, for anxiety, acute agitation, as a muscle relaxant, for sedation, all these different things. You're going to find benzos you get a lot of use in the hospital. Now, what are some of the drawbacks of benzodiazepines? Tolerance can occur. Good. Can addiction occur?
Yeah.
100%, yeah. So again, these are drugs that are going to be controlled substances. Okay, anyone know what schedule they are? C4, the explosive? No. But yeah, they're Schedule 4, right? So we know there is some abuse potential, but we know that they're still an acceptable medical use, right? So they're not on the same par as you would see for something like, oxycodone, which is a C2, but they're still considered a controlled substance. There's still possibility for abuse potential. So if you're writing a prescription for these, how long could you write for? Can I do any refills? So this does not fall under the same restrictions as pain management, right? So for that House Bill 21, those were for C2 pain medications, right? So this does not fall under that. So if I had a patient who chronically needed benzodiazepine, what's the max that I could write for them? 1 year? 6 months, right? Remember, control substance 3 through 5, you have a maximum of 6 months you can write them for. So I could do a month at a time. So I could say fill a quantity of 30 or 90, depending on how often they're taking it a day for a month, and then give them 5 refills. Okay, that is acceptable as a prescription for a C4. Okay, so it's good to keep those delineations in your mind. And when we talked about House Bill 21, that is only to do with C2 pain meds, which is the majority of the pain meds now, right? Because once hydrocodone got bumped up to C2, that basically covered almost everything except for like tramadol. Yes, sir. Potentially, yeah. There's not really many of those like that though. So if like tramadol, you could do 6 months, right? Ketamine is technically a C3, but there's not really any, oral forms I'd be prescribing for that, but that would definitely fall into the same restrictions there. Mm-hmm.
Do you just do like a reevaluation and then prescribe them another 6 months if they needed it?
If you felt comfortable giving them a full 6 months, you could do that. You don't have to. You can give them shorter than that if you wanted to. Yeah, if you want them to come back sooner. For sure. Yeah. And trust me, they will be coming back. They'll say, I need this stuff. Because again, you need to taper people off of these drugs here. Because again, your brain gets used to having that extra GABA effect, and you find this disbalance between GABA and what's the excitatory neurotransmitter? Glutamate, right? Remember, and so if you have all this extra GABA activity, your brain's compensating by increasing glutamate activity, essentially, right? Well, if I take away all that GABA, guess what happens? You have way too much glutamate around. You have way too much excitatory action. You have rebound insomnia, rebound agitation, and potentially, what's the deadly thing? Seizures, right? So you got to really worry about seizures with these patients if they're on it chronically and they're coming off it, just like you have to worry about seizures with alcoholics. They're coming off their medication. Like that's what you have to worry about. Okay. So as I mentioned with opioids. Withdrawal from opioids, while they're going to feel like they're going to die, they're not going to die from that, right? Withdrawal from benzos, absolutely they can die from that, based on the seizures they can develop, okay? Anyway, so as I mentioned, the kinetics are very different depending on the agents here. So things like diazepam has very good fat solubility, so it's a very easy time getting across the blood-brain barrier for good fast onset. However, it's not great for elderly patients because they're going to have fat stores that are going to build up, and they're going to be leaching that out for over a long period of time. That's why we don't like it for that. Usually onset's going to be pretty quick, but it depends on the route. Obviously, what has the fastest onset? IV is going to have the fastest onset, followed by probably IM, intranasal, and then oral obviously would have the slowest onset, right? So you think about the kinetics there. The ones we use IV most often are going to include lorazepam, midazolam, diazepam. Again, you're just going to see these a lot, so you'll kind of get a feel for it, like when you're on rotations and things like that. But keep an eye out for these because you're going to see them used all the time, especially in like surgery and the ER. And just know that fine CYP3A4 will metabolize most of the benzodiazepines. But notice here we have things like lorazepam and oxazepam. They avoid that. And again, who's on a lot of medications typically? Elderly patients, right? So again, that's another reason why we like this a lot in benzodiazepines, especially lorazepam and oxazepam, because they bypass a lot of those CYP3A4 interactions. Okay, just be aware of the active metabolites for some of them, liver dysfunction. So again, if you have an elderly patient needs a benzo, LOTT is the way to go. Okay. As mentioned, CNS depression is the biggest thing you're going to see with this, right? In some cases, you may actually find a paradoxical excitation. This is similar to what you see with like giving like an antihistamine to small kids. Sometimes you'll see they get that paradoxical excitation. Some patients with benzos will get the same thing, so just be aware of that. How do I treat that, do you think? Let's give them more benzos, and eventually I can overpower the CNS, and they'll get sedated eventually, right? And just give them enough of it. But you will see that memory impairment, which can be a good thing, depending on the clinical setting. Or it could be a bad thing, right? If you're using it recreationally, it may not be a great thing. And this will be very synergistic with things like alcohol, right? So they mix this on top of opioids, they mix this on top of muscle relaxants. All of this can be very synergistic and causing a lot of CNS depression, okay? Now, as I mentioned, withdrawal effects are just going to be the rebound effects here. So they're going to be way too excited. They're going to have tremors, sweating, tachycardia, seizures are the big thing I worry about. And so they need to be titrated off of this slowly. And remember, if you have a patient you're worried about going off of these things due to compliance being pretty poor. Again, using a long-acting one with the active metabolites could be a good thing potentially, right? Because that's a longer, longer drop-off in the levels there that may help to mitigate some of those withdrawal symptoms. Okay. BuSpar is going to be sort of an atypical sort of anxiolytic here. It's considered a non-benzodiazepine, has no anticonvulsant action, no hypnotic action, anything like that. This is usually going to be second line. The benefit here is actually not a controlled substance because there's no real, CNS depression or euphoria you get from this. And some people respond pretty well to it, but it does take a few weeks for it to really kick in. Just be aware of that. This is better for more chronic management of anxiety, right? Benzos are great for acute management. Some patients will need it chronically for long-term management, but BuSpar is going to be mainly for long-term management. It has not a fully known mechanism, but it's probably something to do with serotonin helping to work as a partial agonist, like the 5-HT1A receptors, but we don't know the full mechanism right now. And very well tolerated, not a lot of side effects associated with it. Now, beta blockers. Why might we use beta blockers for anxiety? Yeah, for performance anxiety, stage anxiety. So if I asked one of you to come up right now and give the rest of this presentation, might you feel a little bit of anxiety? Probably, right? You'd be like, I have no idea what I'm doing. You're very anxious. So we can use beta blockers to help with that, right? So what this does is it basically will help to decrease the sympathetic effects of anxiety, to help with things like tremor, to help with things like the tachycardia, the palpitations, the sweating, right? And so that's why it's very good from that standpoint to help out in those kind of settings. So if you had to imagine, when you sit down for an exam, you probably feel a lot of those sympathetic effects, right? Your heart starts to race a little bit, you start to get a little sweaty, you're just like, oh boy, this is going to be a bad test, right? Now, would a benzodiazepine be a good option in that case? Why not? It's going to make you a little loopy, you're not going to be able to concentrate on the test, you might fall asleep in the middle of it, right? That might not be a good option. However, a beta blocker could be really good in that situation because it helps to keep the mind clear. However, you're able to still block a lot of the sympathetic effects. You don't feel as anxious, even though you're still anxious, but you're able to perform a little bit better, right?
I'm sorry, this is about the Buspirone.
Yeah.
Is that safe in breastfeeding or pregnant women?
I have to look it up. I'm not sure.
I could have sworn that my doctor used to prescribe that for pregnant women, but
Mm-hmm.
I don't remember. I just wanted to see like the alternative.
That I'm not sure. I know there's a lot more women who are pregnant and breastfeeding. They're using SSRIs nowadays, but I'd have to look it up. I don't know off the top of my head. Yeah. Yep. But anyway, so again, this is good for those situations. So typically propranolol gets used most often, but who might that not be good for? Asthmatic patients, right? Because it's a non-selective beta blocker, so something like atenolol might be good for that. Metoprolol is fine as well. Any of them are going to work potentially. So, and again, you want them to take it typically like an hour before the performance. And you typically want to give them a test dose before they actually need to go at it, right? So again, you don't want them to take it for the first time right before they need to get up and give a big speech, and all of a sudden they're like, you get orthostatic hypotension, they pass out. Not good, right? You kind of have a little bit of egg on your face from that standpoint. So have them test it out beforehand, see how they respond to it, and they kind of get used to it, and then they can take an hour beforehand, give the time to absorb, and then they can be able to perform on their whatever they need to do, right? Give a speech or whatever they have to do. Okay. So again, generally consider what kind of symptoms are they having. Do they have a really acute agitation and anxiety that you need to deal with right now? Short course benzodiazepines are really good for that, right? So you can say, hey, I'm going to start you off on this SSRI. You're going to take this every day, but no, it's not going to kick in for right now. I'm also going to give you a prescription for something like Ativan to take maybe as needed until the SSRIs start to kick in, okay? That way they don't need refills on that, but that way it's bridging therapy until the SSRIs really start to kick in, right? So that can be very useful there. Again, if they're not really having any urgent symptoms that they need a benzo for, go ahead and just start them off on the SSRI, okay, or SNR, whatever the case may be. And then if they're not really tolerating it well, try switching agents, see what they're going to respond well to, and then potentially use the TCA, but usually you like to avoid that if possible, just due to other side effects. Any questions on that? Okay, let me try to finish up this last section here. I'm sure all of your attention spans have getting pretty close to the end, right of the hour. Or like, I need to go do something else and get out of this room. Anyway, let's talk about ADHD. So as far as treatment goes, it's really important to set your goals for what you want for these patients, right? So again, is the goal to actually be able to sit through an entire 8-hour lecture day? Possibly, right? Is it just to sit in a chair still for 20 minutes? Do your homework, whatever the case may be. You need to figure that out, right? So, and again, is it just kids we're treating for ADHD? No, it's a ton more adults nowadays. Either kids that were started on treatment for ADHD that are growing up now, or people who are kind of having late time or later recognition of that. Oh, that's why I've been, so scatterbrained all this time. I had ADHD this entire time. So you're seeing a lot more adults being treated for it as well. And again, non-pharmacologic therapy is going to be very beneficial here as well. So again, making sure that you have good consistent behavioral care amongst different settings. So again, how they're kind of being treated at home is similar to how they're being treated at school, etc. So that way you can make sure that everyone has kind of the same goals in mind. But let's focus on the medications here. Now, it doesn't seem counterintuitive. How do we treat ADHD where they're too stimulated? Give them a stimulant, basically put them on speed to try to refocus them a little bit. Pause for a second. I'm going to keep going. I'll just speak louder. So your stimulants are going to be your first line therapy for this. And so the way they're going to work, these are mostly amphetamine-based drugs, is that they're going to be either, to some degree, blocking monoamine oxidase. This is going to be kind of a minor effect. What they're really trying to do is they're inhibiting reuptake of things like norepinephrine and dopamine. So what do you think that means as far as abuse potential? Why do we get addicted to medications? The dopamine pathway, right? We get those dopamine squirts, just like when you eat a big juicy steak or you have sex or whatever the case may be. You get those dopamine squirts. You're like, oh, that was really good. My body wants to have that all the time now. Same thing happens with it can happen with benzos. Same thing can happen with the opioids. Same thing can happen here with these amphetamines. So what classification do you think they're under as far as the schedule goes? 2. These are all going to be C2 medications, right? So they're under high scrutiny. Now, does that mean you can only prescribe a 7-day supply of these? No, because they're not for pain, right? We're prescribing them for ADHD. So based off the indication, we can do a 30-day supply. And what's the maximum amount that I could write for? 3 months, right? You can only do up to 90 days. So oftentimes what you're going to find when you write these prescriptions out is that you're going to do what a lot of people will do once they kind of get them to like a stable dose is that they will initially go month to month, but eventually they'll go you'll hand the patient 3 scripts, one to fill today, one that will say do not fill until 1 month from now, one say do not fill until 2 months from now, right? And put the specific date on there. So that way the patient can either hold on to the script and then they can take it to the pharmacy, or the pharmacy can potentially hold on to it for them until they're ready to go pick it up. Okay. So again, keep in mind the regulations behind this, because if you work with these patients, you'll get a feel for it eventually. But anyway, so and also you're going to find the amphetamines also help to kind of stimulate the release of catecholamines like dopamine and norepinephrine, right? So these are very stimulatory. What kind of side effects do you expect to see with these? Tachycardia, hypertension, insomnia, sympathetic effects, right? Sweating potentially, hyperthermia, right? All these things you can potentially see because they're basically stimulating your sympathetic nervous system directly, okay? If you've ever seen someone who is hopped up on amphetamines in the ER, you will know exactly what that looks like. They can be very scary potentially, right? There's something called bruxism. Anyone ever heard of bruxism before? You grind your teeth. It can sometimes happen when patients are on amphetamines, and so I'll never forget this one guy. We were on rounds, so we're kind of huddled in the circle, and I hear this grinding sound. It's like, I'm just like, what does that sound? And this guy comes rolling around the corner. He was in handcuffs, in a wheelchair. They're wheeling him over to a bed, but he had been doing a huge amount of methamphetamine, and he was just grinding his teeth. That's why if you ever see people have like meth mouth, they call it, is basically they've been just very poor oral care and they grind their teeth a lot. It's no good.
Whatever it stands for. Is that amphetamine?
It's an amphetamine. That is actually methylene dioxymethamphetamine, or MDMA, is the other name for Molly. And again, sometimes your street names will kind of differ. Sometimes it gets kind of associated with different drugs, but that's typically what we're talking about is MDMA. That one's a little different because it works a lot with serotonin. So when you think about people like with ecstasy, think about them being kind of like huggy, touchy, feely. That's the serotonin effects you see with that. That is a little different than typical amphetamines like methamphetamine, dexmethylphenidate, things like that.
Yeah, because when you go to those festivals, people are wearing these masks because they're going,
Have you ever seen with pacifiers? That's why they're doing it too, so that way they don't grind their teeth down. They can just grind on the pacifier, right? Little things you didn't know. Anywho, there's a lot of good documentaries out there you can look up on rave culture and all the good stuff. Anywho, back to therapeutic drugs you can get medicinally. Basically, if you find that patients don't respond well to one type of amphetamine, you can try switching up, maybe go to a different one in the same class. Dexmethylphenidate doesn't work for them, try dextroamphetamine. Well, I'll give you a list of drugs here in a second. Most of these are going to be available as an extended release product. Why do you think that's beneficial? Think about a school-age kid. give to them once in the morning, and it's going to be working all throughout the day. Otherwise, they have to carry their pills with them, or they have to give them to the school nurse. That could be problematic, right? Don't want to have that happen. And again, these are huge for abuse potential, not only for abuse by the patient themselves, but also for diversion. When I say diversion, what do I mean? They're selling them off. You know, think about high school kids, college age kids are selling these off, things like that, right? So again, can be very fraught with issues here. Anyway, so the different agents we have things like methylphenidate. And again, there's a ton of different brand names that are out there. You have like Ritalin, Concerta, all these. There's even a patch you can administer to the patient for a long-acting action here. You have dexmethylphenidate. Again, a lot of these you're going to see are actually enantiomers of one another. We have what we call mixed amphetamine salts. That's our Adderall. And so that'll usually be a combination of amphetamine plus dextroamphetamine. And we have things called lisdexamphetamine. It's actually Vyvanse. It's actually becoming one of the more popular ones I see nowadays. Now, this one's actually a prodrug that's to be converted over into dextroamphetamine through the liver. Why do you think we'd want to use a prodrug?
Higher bio.
Did I ever tell you about the why we use this as a prodrug? Right, it's to help deter abuse. You can't snort it, right? So a lot of times patients would take these products and they could break the extended release properties of it by crushing it up, and then you can snort it. You know the fancy name for snorting? Insufflation. You hear that? Insufflation. So they're insufflating their amphetamines, but it really wouldn't work because it'd have to take time for it to actually get back to the liver to get converted over. So it really didn't give them that same kind of rush as you would see if you crushed up an Adderall. So by using this as a prodrug, it has to get taken in orally, gets metabolized, and then it will kick in. So that's one thing that I've seen, but a lot of patients just really respond well to it, so a lot of people are on this. You'll see this quite frequently. And they're all going to be C2s, so again, they're all under that same sort of scrutiny and regulations. Now, will this show up on E-Force, do you think? Yeah, any controlled substance is going to show up on E-Force. C2 through 5 are all going to show up there. Does C1 show up there? You can't prescribe C1s, right? Yeah, so those do not show up. But yeah, any of these would show up. So you can actually find out, okay, well, how they've been filling this, what have they received in the past, how often are they getting it, etc., right? Because again, if you're seeing multiple prescribers all prescribing the same drug to the patient, that could be a red flag, right? You could be like, okay, something weird's going on here, right? That can be, or if they're not filling it, in a timely manner, as when you're prescribing it, like something, might be going on. So you can look for things like that, right? Anyway, so looking at adverse effects, again, you can see, oh, yes, sir. So, not that I know of. I think because it's going through medical marijuana dispensaries and not through typical pharmacies, I don't think that they are regulated by under the same purview, and I don't know that they have to respond to that. Because it's different, because you don't even necessarily get a prescription for the medical marijuana. They basically will give you, say, you're authorized to purchase this much medical marijuana, say, in a month. They still track that. I just don't think it shows up on E-Force. If you know anyone who's on medical marijuana, maybe we can look them up later. I'm just kidding. You don't want to do that. Get HIPAA, right? You don't want to be just looking up like, hey, I'm dating somebody new. Let me just check them out. Like, don't do that. Highly unethical. Okay, don't do it. Anyway, good question though. But yeah, so just real briefly, so some other things you're going to see with these agents. So you can see reduced appetite, weight loss. Why is that might be a problem? Huh? Yeah, because if you think of little kids, like they're actively growing, right? You want them to be able to put on weight, right? So that's one thing you worry about growth stunting with some of these kids here. Certainly insomnia, you see irritability, tachycardia, hypertension, all of these are expected. You can see a black box warning for all of these amphetamines. They can cause psychotic episodes, hallucinations, abuse, and dependence. Okay, so be very, very aware of this. You have patients who are on basically amphetamines all the way through school, and all of a sudden they graduate and their prescriber says like, well, you're done with school. We don't need to prescribe this to you anymore. Guess what? They're still physically dependent on this stuff. They still need it. And when they are taking that away from them, what happens? Sometimes they got to resort to some nefarious means in order to get their medications. There's a lot of really sad stories out there about that. So you need to make sure these patients are tapered off as well, because you worry about that, right? To the abuse potential. Anyway, so again, be very careful about using this in patients with history of substance abuse, because again, they're more likely to be getting addicted to other substances as well. And then I mentioned the withdrawal effect. So what do you think withdrawal from these medications looks like? Yeah, so it's kind of the opposite. So again, with the CNS depressant, the opposite effects you see are happen with withdrawal. So if I'm giving you benzos and I take that away, you see rebound insomnia, rebound anxiety. Here, kind of you see the opposite effects of the stimulant. So you kind of get this kind of slowing down. They're just kind of mopey, you know, kind of not a whole lot of energy, that kind of thing. So it's not as severe as you would see with something like a benzo, but they certainly still have that psychological craving for the medication. That certainly you can still see that. So just be aware of that. And again, oftentimes, especially with small kids, when you're worried about the growth stunting effects, you will give them what we call drug holidays. And again, what is a drug holiday? It's not spring break, right? Yeah, you stop the medication. Again, when's a good time for kids to stop the medication? Summertime, right? So they're out of school, say, hey, you don't really need the medication. Let's go ahead and wean you off of it, and then you're good for a few months. And then when you get back on school, go back on it, right? So again, that is good to help kind of decrease the total, lifetime amount of amphetamines they may need to be receiving there, okay? Anyway, so there's a few non-stimulant agents we can try using as well, especially if you had a patient with a history of substance abuse. And so things like atomoxetine or Strattera. This is actually an SNRI. We don't use it for depression, though, for whatever reasons. Maybe it has a little bit different spectrum of activity. But as you might imagine, it has a slower onset of action than the amphetamines. Amphetamines, the second you take it and it gets in the system, it's going to be working pretty well. Versus atomoxetine will take a few weeks, just like we see with other, SNRIs like that. Again, no abuse potential is great. And the side effects are going to be very similar to what we saw with the SNRIs. Still that risk for suicidal ideation, right? Just like we see with any of the other antidepressants. Next, we have our alpha-2 agonist. This includes clonidine and guanfacine. Guanfacine probably gets used a little bit more frequently for ADHD nowadays, but what do you think these drugs do? Yeah, so basically they will help, if they're overstimulated, we can give them alpha-2 agonists to try to decrease catecholamine release, right? So we can see things like bradycardia, hypotension, sedation seen with these. And so these are oftentimes not used as first line, maybe used as a backup, or oftentimes, and again, do you necessarily want to treat side effects of medication with other medications? No, it's not a great cycle to get yourself caught into. But what I will see a lot of cases, patients will be on amphetamines during the daytime, and then when they go to sleep, to bring them back down so they can actually go to sleep, they'll be on something like clonidine or guanfacine. Not a great cycle, but if it works for the patient, it works, and it's just the way it is. I saw a patient the other day who was coming in for constipation, coming in for a clean out, and was a teenager, and they happened to be on Abilify. They were on clonidine. They were on Vyvanse. They were on hydroxyzine, which is antihistamine. They were on, what else? I think clonazepam. They were on, I mean, the list of medications was huge, and so, of course, GI was the admitting service. The kid had a huge host of behavioral health issues. And so I called the nurse practitioner for GI, and I was like, hey, first of all, I was like, all these medications are current, because a lot of them were double duty. They were on, they're on Zyrtec and hydroxyzine at the same time, which are like, and Claritin at the same time. I'm just like, what's going on? And she's like, yeah, they said that's all they're taking. I said, well, like half these drugs cause constipation, right? She said, I know. I'm just admitting them just to do the clean out. I'm like, well, they're going to get constipated again. She's like, I know. Because again, if you're the GI person, do you want to go mess with all the behavioral meds they're on? No, if they're on that many meds, there's probably a good reason why they're on that many meds. However, it stinks because now we got to admit the patient, give them a bunch of Miralax. Yeah, it will stink, right? Because the patient's got to get an NG2 placed in. They have to go lightly so they can flush them out, and it's not great. It's like it's one of those things where we're having to treat the side effects of a lot of other medications with other medications, and now they have a hospital admission on top of it. So again, be very cognizant when you're adding on new medications to this list, because again, you can see some pretty significant outcomes with that, right? So just something to consider. Anyway, again, sedation is going to be the biggest side effect seen with these. Hypotension and constipation is another thing you can see potentially. Okay. Just so you know that for ADHD therapy, it has to be really individualized, but typically you're going to be focusing on the patient factor. So do they need extended release versus immediate release products? There's actually some liquid preparations of these amphetamines we have nowadays that you can use for smaller kids. And typically start with a stimulant. Let's have some contraindication. Then potentially use a non-stimulant, and then potentially consider antidepressant therapy as well. Usually second or third line. See if they maybe have some other kind of underlying behavioral health issues that maybe can be helped with this like an SSRI. So consider, is it the fact that they have ADHD, or they just have a lot of anxiety associated, and that's helping them or preventing them from really concentrating? Maybe an SSRI would help with that, right? Because it tends to be not as quickly, it is not as effective as quick as a ADHD or as a one of the stimulants, and it's usually not as effective as a stimulant. We find the stimulants to be really, really effective, really great, even though we know there's a host of issues with them. So that's kind of why we do that. I will tell you though, is like, before you have to take a test or anything like that, make sure the patients kind of know how the drug's going to affect them beforehand. Because I will tell you a little story. just real briefly before I let you go on a break. This was, I was in undergrad, so again, before I knew anything about pharmacy or drugs or anything like that, and I was taking Anatomy and Physiology 1. We had our lab final. Have I told you the story already? Okay, so we had our lab final. Basically, you go walk into a room, and it looks like a horror movie because it's like full of dead cats, full of little pins in them. You had to go through and identify all the different organs and muscles and stuff. You guys probably have done that at some point in your life, right? So this is our lab final, right? So this is where you had to go in and actually like identify all the structures, and that was our final. We had to pass that, right? So anyway, so I had a friend who was taking the class along with me. It was an 8 o'clock lab. So, you know, those are just so painful, right? Like 8 o'clock classes are still painful, as it turns out. But this guy was, he was, you know, kind of, he had this new girl that he was kind of smitten with, and he was up all night with her. And he realized, oh, I still need to study for this exam. Oh, no. And so he had a friend who was able to get a dose of Adderall from. He says, oh, I will take this. This will help me to stay up all night so that I can study, and then I will do well in the exam in the morning. I'm telling you this story. How well do you think that worked out for him? Not great. So he showed up in my dorm room that morning, picked me up because it was on the way. And so he showed up, and he's like, all I hear is, like, hey, what's up? And he's like, all right, ready to go? Let's go. Let's do this. You know, he's kind of a small guy, but like the dose he take was way too much for him. And so we were trying to review on the way there, and I'd never seen someone with such bad, like, you know, flight of thought, and he could not concentrate on any one thing at all. So imagine having to walk into a room and be able to carefully look at this cat carcass, basically, and try to delineate what muscle is this versus this muscle, what structure is this, and he failed utterly. Like, just had to retake the entire lab. So again, be very careful with these medications. There's a lot of abuse, and a lot of people may not just think like, hey, I need to stay up, I need to study a little extra. Like, warn them on this kind of stuff, because again, you can see some big issues with this. I know it sounds like I'm a narc and it's like, you know, don't do drugs, but don't do drugs. Like, they're bad, right? And educate your patients on the dangers of that. Like, hey, it may seem like it's nothing, like it's just a normal routine med, but you know, some of these patients have really worked up to a pretty high dose on these things, and if you were to take it as an amphetamine naive person, you can see some bad effects from it, right? Anyway, so don't do drugs. That's what I meant. There. So let's go ahead and do a 10-minute break. We'll come back and get into the neuro section.